Dr. Vignesh, who's a senior consultant at Apollo Hospitals on Greens Road. And he's going to talk to us about ECMO in poisoning, the rationale and the evidence and our experience. He has in fact published our experience of having treated, Vignesh, how many patients are there in our cohort?
We published 3 patients, sir.
Three of our patients. There's a case report that he has published on how we managed, and he will be presenting that too. Over to you, Vignesh.
Very good morning to everyone. Thank you for the opportunity. Today I'm going to discuss about the role of ECMO in poisoning. In this, I'm going to first enumerate the rationale why we consider ECMO in poisoning, and also is there any evidence to support the use of ECMO in poisoning. And also I'm going to share our experience in managing such patient with ECMO. So this is one of our patients. This is a 19-year-old male patient admitted to ICU 24 hours after consuming 150 milligram of amlodipine and 750 milligram of atenolol. So he was admitted elsewhere where the initial resuscitation was done. In that hospital, they gave fluids, started on vasopressors. Since there is a bradycardia, they inserted pacemakers, temporary pacemaker, and then shifted here because patient was not getting better. On presentation, his heart rate was 70 on TPI. His blood pressure was 90/50 with triple vasopressors. So on arrival, we managed him aggressively with the recommended dose of IV fluids, calcium gluconate, high-dose insulin, glucagon, and intralipids. But after all this resuscitation, patient condition didn't improve. His condition keep on deteriorating. The vasopressor requirement increased. He had cold peripheries. The urine output came down, and there was increase in lactate. So what to do? Here we have a patient, young patient, who consumed amlodipine and atenolol. All our medical management is failing. So in spite of aggressive treatment, his condition is not getting better. So before going to what to do, why he is not getting better? So why this hypotension? There is a refractory hypotension. Most of the cardiotoxic poisons can have one of these mechanisms. Cardiac dysfunction, it may be because of the suppression of adrenergic receptors, or some of the toxin can have a direct cardiotoxic effects. Some of them have ischemia. So all these things can cause a cardiac dysfunction, which can precipitate hypotension. Some of the toxin can cause a nodal dysfunction, which can cause a bradycardia. Membrane stabilizing agents can have a refractory arrhythmias, which can cause hypotension. Vasodilator potential agents with vasodilator potential can have vasoplegia, which can induce hypotension. And we cannot rule out hypovolemia in such patients. So hypovolemia can also contribute to hypotension. So what happens here is there is a hypotension, refractory hypotension, which can cause an hypoperfusion, and this can in turn induce inflammation and cause coronary ischemia. This can once again cause a cardiac dysfunction. So it forms a vicious cycle in cardiac level. When you take into the systemic circulation, there is hypoperfusion and hypoxia, which can cause multi-organ failure. So we have to understand this. Then there is hypotension and hypoperfusion. The main organs like kidneys and liver can also get dysfunction, and most of these toxins are excreted by the kidneys or liver. So if there is a kidney and liver dysfunction, these toxins get retained and the toxic effect keeps on recurring. So we have to stop this vicious cycle. So how ECMO helps in such condition? So it overturns these low cardiac output states. Once you put the patient on ECMO, the flow is maintained. So these vicious cycles of self-inducing cardiac dysfunction is stopped. So the main purpose of putting a VA ECMO in such patient is to maintain the hemodynamics and tissue perfusion. In case of inhaled toxins, where there is a primary pulmonary toxicity, where there is hypoxia, we can use it for maintaining gas exchange. The other reason is facilitating of elimination of these toxins. So since ECMO maintains the perfusion to the kidneys and liver, the toxin elimination can be facilitated by putting the patient on ECMO. So how to decide on putting on ECMO? So if there is a severe intoxication, patient presenting severe intoxication, most of the patients will invariably be present with severe hemodynamic instability. Here we start with conventional management with all the conventional therapies. If the patients worsen on this conventional therapy, like the hemodynamics, clinical parameters, as well as the metabolic parameters deteriorate, then we have to consider ECMO. So we have to weigh the risk-benefit, the indication and contraindication, and we have to decide about ECMO. The common indication for ECMO in this setting is recurrent cardiac arrest. So many patients can have a recurrent cardiac arrest, or refractory arrhythmias, refractory cardiac failures, or severe vasoplegia. So these condition can induce a severe refractory hypotension. So if we come across this condition, the most common purpose of using ECMO is as a bridge to recovery. So as long as the toxins are there in the system, the toxicity is going to present and the patient is going to have a refractory hypotension. Once the toxins are getting eliminated, patient condition will recover. So the common purpose of putting the patient on ECMO is a bridge to recovery. There are lots of toxins which can be removed by dialysis or hemoperfusion. We can use ECMO as a bridge to renal replacement therapy. So we can put the patient on ECMO, start hemodialysis or hemoperfusion, remove the toxins, patient will get better, and then we can take the patient on ECMO. And you can use as a bridge to antidote. So some of the antidotes cannot be easily available. For example, digoxin. The digoxin, we have an antidote called antibody, which is not freely available. So till we get the antibodies or the antidotes, we can put the patient on ECMO. As soon as we get the antidotes, we can give the antidotes. Patient will recover, and then we can take out the ECMO. And finally, bridge to transplant. So there are few toxins which precipitate irreversible damage. For example, paraquat, which can induce irreversible damage to the lung. In those conditions, we cannot anticipate a recovery. So in this situation, we can put ECMO as a bridge to transplant. In case of vasoplegia, so though ECMO can maintain the flow, we have to increase the systemic vascular resistance. We can add the vasopressor along with ECMO. There are other set of patients where the patient presents with pulmonary toxic agents like inhaled irritants, which can induce ARDS. They will present as a severe hypoxia. In those cases of patients, they will be hemodynamically stable. In such patients, we can plan for a VV ECMO. So once we decide on putting the patient on ECMO, what is the ideal time to place on ECMO? The ELSO suggests drug intoxication as one of the indications for putting the patient on PV ECMO. Various studies have used various criteria in describing cardiogenic shock. ELSO describes a systolic blood pressure of less than 90, urine output of less than 30 ml per hour, lactate of more than 2, SCVO2 of less than 60, altered consciousness for 6 hours despite all possible aggressive treatment as the indication for putting the patient on ECMO. So whenever patient comes with a severe shock, you just resisted the patient to all possible aggressive treatment. Despite all this aggressive treatment, the patient condition is not getting better. That is the ideal time. Ideally, we have to start the ECMO before the organ failure set in. Okay? So is there any concern of using ECMO in toxicology? On volume of distribution of toxin. So ECMO involves a circuit, extracorporeal circuit. We use priming fluids. There is an oxygenator and there is a pump. Okay? The toxin whichever is there in the system, the volume of distribution increases, which can hamper the elimination of the toxin. The second is the bioavailability of the antidotes. Few of the toxin we can use antidotes. These antidotes also can be trapped in the ECMO circuit, which can reduce the availability of these antidotes to counteract the toxin effect. And we also need to look into the interaction of the medication which we use in toxicology with ECMO circuit. This is especially true with intralipids. Intralipids we commonly use for beta blocker, calcium channel blocker, as well as local anesthetic toxicity. So there are lots of case reports which describe the intralipids used in ECMO. Whenever you use intralipids can clog the ECMO circuits, it can clog the membrane oxygenator and can cause circuit failure. So whenever you're using these medication, you have to keep in mind about the possibility of the circuit failure. So is there any evidence to support these rationales? So the rationales look sound. So if patient is coming with a reversible cardiac failure or a respiratory failure due to toxicity, support the patient with ECMO for some time, and patient gets better once the toxic effect goes off. Whether there is an evidence to support this. Unfortunately, all we have is a level 3 evidence. The data are limited to animal studies, case reports, and case series. There are no randomized controlled trials to support our claim. And it is also not feasible to conduct randomized control trial in this because we are dealing with heterogeneous toxins. There are thousands of toxins described in the literature, and each and every toxin there are variable kinetics and dynamics. So it is not possible to compare each and every toxin, the outcomes of each and every toxins. Second, the sample size are limited. So as we see the case series which we have been described over a period of 10 years or 15 years, only 15 or 20 patients are there in each case series. So it is very difficult to take adequate sample size to do an RCT. And there will be some ethical concerns in doing RCTs in this kind of patient. For example, if a patient is having a cardiac arrest, whether to put on ECMO or not to put on ECMO, so there will be an ethical issue in doing these studies. There is no death in case reports. There are lots of case reports. All these, you have case reports in all these agents, and there have been successful outcome in these case reports when they use ECMO in all these toxins. However, the case reports has a publication bias. Okay, the authors will publish only if it succeeds. So if it fails, there won't be any publication. So you cannot go with the case reports. So I'm going to highlight the important case series which have been published recently, which has relatively large cohorts. 3 case series have been published. One is the Daubin et al., Masson et al., and the Venus. The initial 2 is from the French hospitals. So you can see the case series covers a period of almost 10 to 15 years. And the common indication for initiation of ECMO is either a refractory shock or a refractory cardiac arrest. In the first case series, if you see, there are 17 patients in which ECMO was placed for toxin-related cardiac failure. Among these patients, 10 patients had a cardiac arrest and 7 patients had a refractory shock. The survival, almost 76% of the patients survived. 13 of 17 patients survived in this series, and they reported high incidence of vascular complication in this case series. The second one is done in 2 French centers, and it was done over a period of 10 years. Here also the indication was persistent shock and cardiac arrest. So 62 patients had this condition of persistent shock and cardiac arrest. Among these, 14 patients So among these, 14 patients underwent ECMO and 48 patients are managed with conventional therapy. The overall survival was 56%. Among these, 86% of the patients who was on ECMO survived, and 48% of the patients who underwent conventional therapy survived. And they also found out that patients who had a beta blocker poisoning and who was on extracorporeal therapy, the outcome was better. The outcome was better when they had an agent with a membrane stabilizing activity. ELSO registry, this is the largest cohort we have so far. So this was done a period from 2003 to 2018. So they assessed 113 patients who underwent ECMO for toxicology indications. The overall outcome was 52.9%. So they also identified that whenever they initiate on ECMO, there is improved hemodynamics, gas section, and acidosis, which was noted in this cohort. So coming to our experience, this is a case. This was the initial 3 patients which we managed in our hospital. We published in our AJCCM. So the initial 2 patients was of relatively lower age group. So the first patient is 29 years old female, presented with amlodipine toxicity. The patient took 400 milligram of amlodipine, and she presented early to us. She presented within 8 hours of consumption. So as you can see, the patient had a severe hemodynamic instability. After initial resuscitation, aggressive initial resuscitation, patient persists to have severe hemodynamic instability. You can see the amount of vasopressors required for her, and you can see the lactates. In spite of all the aggressive therapy, the lactate levels were increasing. The second patient, which was described earlier, it was a 19-year-old medical student. He consumed amlodipine and atenolol. You can see the Apache score, which he presented. It was 31, and he presented 20 hours after injection. So he went to another hospital. The initial resuscitation was done, and then he came here. So you can see the amount of vasopressors he was requiring. He was almost requiring 4 vasopressors and inotropes. And you also can see that the acidosis and lactates were increasing. And third patient, it's a 17-year-old female. She presented with polypharmacy, which included beta blocker and amitriptyline. So Apache score was 23, and she presented late. So she was from another city. The initial resuscitation was done, and she was sick, so they transferred here. And she had a cardiac arrest when she arrived here. So we almost done a 30 to 40 minutes of CPR. You can see the lactate level before just putting on ECMO. So it was almost 25.15. So we placed ECMO on the peri-arrest condition, and the vasopressor requirement was also very high. So all these patients were initially treated aggressively with usual medical management, including fluid resuscitation, high-dose insulin therapy, calcium gluconate, glucagon, lipid emulsion, as well as sodium bicarbonate. So in spite of all these aggressive treatment, patient persists to deteriorate. So you can see the effect of ECMO in these patients. In all these 3 patients, within 4 to 8 hours, we are almost able to wean off the vasopressor support. So first patient, you can see, immediately after initiation of ECMO, within 4 hours, we are able to completely wean off the vasopressor, except minimal dose of adrenaline was continued for the vasoplegia effect. In other patients also, you can see we are almost able to wean off the vasopressors immediately. When you see the metabolic parameters, the lactate consistently decreased immediately after initiating ECMO. So all these 3 patients survived. So we are able to initiate ECMO within 12 to 18 hours of admission. And the duration of ECMO in all these patients were somewhere between 2 to 4 days. The mechanical ventilation duration was almost 10 days. ICU length of the stay is almost 8 to 10 days. The third patient, she had lots of complications. This patient, it was initiated in the peri-arrest condition. We initially initiated on peripheral VA ECMO, but we couldn't achieve flow with the peripheral VA ECMO, so we have to convert it into a central VA ECMO. And subsequently, she had a major bleed. We had to do a re-exploration and achieve hemostasis. She went on to have a multi-organ failure, and subsequently, slowly she recovered and she went home. The second patient, we had a limb ischemia. In spite of putting a distal perfusion cannula, patient had a compartment syndrome. We had to do a fasciotomy, and slowly patient got better. So after this, subsequently, we had another four patients. We managed toxicological patient. We managed with ECMO. The other 3 patients was relatively elderly age group, 62 to 75 years of age, and they have multiple comorbidities. So the fourth patient, we had a patient had a diabetes, hypertension, and coronary artery disease and post-COVID status. She had a polypharmacy overdose. She had a calcium channel blocker, ARBs, clomiprid, and metformin. This patient also had a cardiac arrest when she reached here, and she had a severe lactic acidosis secondary to the metformin toxicity. So VA ECMO was initiated promptly, and she was supported with renal replacement therapy and hemoperfusion. We were able to wean off ECMO on day 3, and she was discharged home on day 9. She had left foot ischemia, which required some debridement and skin grafting, and overall she did well and went home. The fifth patient, we had a 75 years old male, elderly gentleman, diabetic, hypertensive, and a post-CABG status, presented with amlodipine overdose. He also had a refractory shock in spite of aggressive initial management. We initiated on VA ECMO, and he required RRT for acute kidney injury. His hemodynamics gradually improved within 5 days, and we are able to decannulate him after 5 days. But subsequently, because of his elderly age and comorbidities, he had multiple wave of sepsis and succumbed to multi-organ dysfunction and sepsis. The next patient we had is a 65 years old female, diabetic, hypertensive, had hypertrophic cardiomyopathy, hypothyroidism, and rheumatoid arthritis, presented with verapamil overdose. It was an accidental ingestion. So she had a refractory shock and bradycardia. She required pacemaker insertion. And despite aggressive treatment, she had a persistent shock, so we had to put on VA ECMO. Within 4 days, we are able to decannulate her. She was discharged after day 10. She had an AKI which was managed conservatively. This was the last patient we had last month, 31 years old male patient. He had no comorbidities. He presented after ingestion of 200 ml of paraquat, which is a toxic dose, lethal dose. On presentation itself, he had an acute kidney injury and he had an ARDS. Initially managed with hemoperfusion, and aggressive immunomodulation was given in terms of pulse steroid as well as cyclophosphamide. In spite of initial therapy, he had a severe ARDS, so we had to initiate VV ECMO for gas exchange support. Subsequently, because of paraquat, he had a multi-organ failure. We had to support with RRT. He had an acute liver failure. We did plasma exchange to support that, and IV antibiotics were given for his infection part. He was managed on ECMO for 19 days. Subsequently, he had multi-organ dysfunction secondary to paraquat toxicity, and then he also succumbed. Overall, our experience, we had managed 7 patients. 5 patients got better and went home. 2 patients who expired, one was an elderly gentleman, 75 years, had multiple comorbidities, whom we were able to wean off the ECMO, however, he succumbed to sepsis. The last patient which we lost is a patient who consumed lethal dose of paraquat, where we gave ECMO support as a bridge to transplant, because we know that with paraquat, the recovery of lung is not feasible. However, because of multi-organ failure, he succumbed. So to summarize, the role of ECMO in toxicology, there is a strong physiological rationale. However, we don't have adequate data to support the claim. And there is also a challenge we face in doing a good quality RCTs in this. The experience we have has been encouraging so far. So whenever a patient comes, just concentrate on initial management with aggressive medical management. If the patient is not responding, I think we should consider putting the patient on ECMO. At least we should offer the patient ECMO. Thank you.